Okay, well, good morning, everyone, and welcome to our grand rounds this morning. It's my pleasure to introduce three speakers that are all very well known to, I think, everybody in the room and most of you out there. It's our three senior hospitalist fellows. Two of them did their residency in Phoenix Children's, and so they've been here for at least 5 years, and one of them is finishing his second year. So I'll introduce all three of them at the same time right now. And then we'll each will talk for about 15 to 20 minutes or so. And if we're on schedule, we'll actually take questions after each of the 15 to 20 minute segments. If we run behind, we'll save all the other questions at the end. So you may have two chances to ask questions for the first two speakers. First of all will be Dr. Jared Kuzma. In addition to being a pediatric hospital medicine fellow, he's actively pursuing a master's in clinical research at the University of Arizona. He did his residency here at Phoenix Children's and then spent 1 year as chief resident. And his main fields of interest include predictive algorithms and artificial intelligence with a focus on pediatric infections. Following him will be Merritt Tenhope, who's also been at Phoenix Children's for nearly 5 years now, having completed her pediatric residency in 2022. She will graduate in June, as will the others, and Merritt is very passionate about social determinants of health and how they impact the well-being of children, both inside and outside the hospital. In line with these interests, she's pursued her QI project during residency and now a research project during her fellowship on this topic, which she's going to cover in today's session. And then thirdly, Sagar Shah graduated medical school from Oakland University, William Beaumont School of Medicine, and then did his residency in pediatrics at the Children's Hospital of Michigan, Detroit. Currently, he's working also on a master's degree in medical education through the University of Cincinnati with a focus on curriculum development. And unfortunately for us, Sagar will be joining the Pediatric Hospital Medicine Division at University of Texas Southwestern in Dallas this summer. We sure would have loved to have him stay here too. So without further ado, Jared, take it away.
So I'm Jared Kuzma, for those who don't know me. And my project during fellowship was the effect of comorbid viral illness on the utility of procalcitonin as a predictor of bacterial infection in infants 8 to 60 days of age. A little bit of background on this study. Procalcitonin is produced in the thyroidal T cells, where it's then converted to calcitonin in response to hypercalcemia. And it can also be produced in your adipocytes in response to inflammation, which can be burns, infection, trauma. When it's produced there, those tissues lack the necessary enzyme to convert procalcitonin to calcitonin, which results in an elevated level. Which is why it's been studied as a marker of infection. A potential barrier to this, though, is that viruses are a common source of infection, and they're theorized to induce cytokines such as interferon gamma, which actually may inhibit procalcitonin production. If you're looking at this graph here, the top is your adipocyte cells and the bottom is your thyroidal T cells, and just kind of shows that general process. So current practice for febrile infants under 60 days of age, as we all know, they routinely undergo evaluation due to their infection risk. And recent studies have really been trying to investigate ways to reduce their diagnostic procedures and hospitalizations. One way that this is being done is procalcitonin in adult studies was shown to be associated with bacterial infection when elevated. And studies have also shown that it's actually a highly specific marker for bacterial infection in febrile infants. Current protocols that are used, such as Rochester, Boston, Philadelphia criteria, don't include procalcitonin, but now with the new research into it, more recent protocols such as the AAP infantile fever guideline that came out in 2022 now actually includes it as an inflammatory marker. And that's really what this slide here is to show. This is from the AAP infantile fever guidelines for 22 to 28 day olds. I just picked one of the 3 age groups to focus on. And here in the red circle, you can see where they say if they have abnormal inflammatory markers, yes, you do not lumbar puncture. No, it's up to clinician decision. And they define those inflammatory markers as procalcitonin over 0.5, which is bolded, CRP over 20, or ANC over 4,000 if the institution can draw procalcitonin. And if not, they use an ANC cutoff of 5,200. So the objectives of my study, knowing that procalcitonin is being used more and more frequently, but we haven't really looked into viral infections impact, is one, determine if the presence of a confirmed viral illness impacts procalcitonin level in patients with and without a bacterial infection, and two, to assess the statistical accuracy of procalcitonin in the detection of bacterial illness when a comorbid viral illness is present. This was a retrospective cohort study looking at infants aged 8 to 60 days who presented with documented fever of over 38 degrees Celsius between 2018 and 2020. They were identified via ICD-10 codes for fever or bacterial infection. We used a whole lot of codes that were actually in our infantile fever pathway. Exclusion criteria of any patient under 37 weeks, if they were previously admitted for an infection or to an ICU, NICU, or PICU, if they've ever been on antibiotics prior to this current visit, if they had any complex care needs, if they did not have a known temp over 38 Celsius, this included either parents reporting a true temperature at home or a true temperature in the emergency department or urgent care or on the floor. And finally, they were excluded if they did not have blood and urine cultures of procalcitonin collected or a respiratory viral panel. And the respiratory viral panel, we were pretty specific on if they tested positive for a virus on any sort of viral test, such as a rapid or the respiratory pathogen panel, they were included. If they tested negative, it had to be a negative RPP because we want to make sure we really tested for the most possible viruses. And then we collected the procalcitonin levels, bacterial cultures, and viral PCR results. And then we grouped patients based on their testing. So we had our bacterial positive, so your BI positive. These are patients who had growth on a urine, blood, or CSF culture. The treating clinician documented that they thought it was a true infection and not a contaminant. And the infant received appropriate antibiotic treatment for the presumed infection. That was really to catch those who didn't, documentation might not have been as clear if they thought it was contaminant or not. And then your bacterial negative were those who had no growth on bacterial culture. And for your viral patients, viral positive, like I said, had to be a positive viral test on any viral testing. And a negative viral patient had to be a negative viral test on the respiratory pathogen panel. And then using those results, patients were categorized into 3 groups. You had your bacterial positive group, your bacterial and viral positive, so those with a comorbid viral infection, and then your no infection group. We then compared between these paired patient groups using the Wilcoxon rank sum test because the patient's procalcitonin levels were not normally distributed. Whoops. And then we did that for the entire cohort and also stratified by age. We used the 8 to 28 and 29 to 60 day age range because we didn't have a large enough patient population to look at just that 22 to 28 day group. And then we used logistic regression and area under the curve analysis to assess the odds of bacterial infection in febrile infants with and without a viral infection in the setting of an increased procal. So just showing you our demographics, we had a total 259 patients that met all criteria. And we did in this, for this part, we did exclude those who were only viral positive because we didn't find that that was as relevant for this part of the study. We had 100 patients in the 8 to 28 day group and 159 in the 29 to 60. Had a pretty good breakdown between the no infection group with 138, 73 who were bacterial only, and 48 had both bacterial and viral. The biggest thing to note here is we did have more males in every group than females, which is consistent across other studies that have looked at this patient population. And then looking at the first wave results of comparing procalcitonin values between febrile infants in these 3 groups. In the first column, you had your group with no infection with a median procalcitonin value of 0.1. In your bacterial only group, the median was 0.89. And in your bacterial plus viral, the median value was 0.36. And the big thing to note here is that the 0.89, the bacterial only group, was significantly higher than either of the other groups, both the no infection and the bacterial plus viral. And the bacterial plus viral group also was significantly higher than the no infection. So showing that the presence of virus does seem to suppress procalcitonin levels, but it's still, that bacteria still overpowers enough to make it significantly higher than those with no infection. And then this is our receiver operating curve for procalcitonin usage in distinguishing bacterial infection in febrile infants. The blue line is looking at those who are viral negative, so bacterial only versus no infection. And then the red line is actually looking at your viral positive, so patients bacterial plus viral versus patients with only a viral. And the next slide will kind of break down the results from this, but the big thing to know from any receiver operating curve, the more area under it, the more accurate the testing. So it does, procalcitonin does impact that the viral presence impacts the accuracy of procalcitonin just because that red line is more flat with less area underneath it. So using those curves, we then looked at the predictive ability of procalcitonin. In the first column, again, we have our bacterial versus no infection. And in the right column, we have our viral positive, so bacterial and viral versus viral only. You can see that the odds ratio, so every point that procalcitonin increases the odds of an infection being present by 1.15 in the bacterial only group, while in the bacterial plus viral, it actually goes up by 2.98. So an elevated procal is even more concerning based on odds ratio if they have a virus than in those with no virus. The area under the curve also shows that procalcitonin's overall accuracy does drop when a virus is present. And then the big thing to take away here is looking at sensitivity and specificity. So the sensitivity of a procalcitonin using a cutoff of 0.5, which is a very well accepted cutoff, is 68% in those with a no virus, while it drops all the way to 44% if they have a viral virus present, while specificity actually stays pretty much the same at 0.9 at 93 to 96%. So for those who need a reminder about sensitivity specificity, basically what this is saying is that if your procalcitonin level is above 0.5, if they have a virus or don't have a virus, it's still very concerning for a bacterial infection. While if it's less than 0.5, and they're viral negative, you just don't really know what to do with it because that sensitivity is poor. While if they're viral positive and it's less than 0.5, procalcitonin really tells you nothing because that sensitivity is all the way down there at 44%. So the key finding from our study is that there is a significant decrease in procalcitonin level for febrile infants with both a bacterial and comorbid virus when compared to those with bacterial alone. But those with comorbid viral infection still had a significantly higher procalcitonin than in those infants with no known infection. The specificity of procalcitonin remains consistent around 93 and 96%, while the sensitivity of procalcitonin decreases from 68 to 44%. In conclusion, procalcitonin is highly specific for bacterial infection in presence of a known virus. And this was actually the first report of the impact of confirmed viral illness on procalcitonin levels in febrile infants. And the main takeaways, procalcitonin has poor sensitivity and it worsens when a virus is present for the detection of a bacterial infection. So in the setting of a low normal procal, practitioners still need to consider the clinical picture and other markers of inflammation to determine their risk of bacterial infection. But on the flip side, procalcitonin is highly specific, irrespective of the presence of a confirmed viral illness. And thus, if procalcitonin is elevated, doesn't matter if they're viral positive or not, we still should strongly consider workup and antibiotics for those patients. Next steps, we really want to expand our data collection and analysis to include other markers of infection, such as ANC and CRP. And then using that, creating an odds calculator for the presence of bacterial infection in febrile infants, and also narrowing the range because we currently included patients with UTIs, which we now know is not as serious as bacterial meningitis. So we, by expanding our patient population, by going multi-center or increasing the number of years we look at, we really want to focus in on that bacteremia meningitis, those invasive bacterial infections. And looking at that, we have started the next analysis. So as a quick overview, this is looking at ANC. Sorry, I don't know why it says procalcitonin on top, but this is the absolute neutrophil counts and actually is consistent with procal. The ANC is significantly higher in those with bacterial alone versus those with a comorbid virus or no infection, but those with a comorbid virus still have a significantly higher ANC than those with no known infection. So very much the exact same picture as procalcitonin. And looking at its area under the curve analysis, almost identical results where sensitivity drops if a virus is present while specificity remains the same. This is just thank you to everyone who's assisted me with this study. And just to show, this work has been distributed and has now been published in Hospital Pediatrics. And that's just a list of references, and we'll pause there for questions before I hand it over to Merritt.
Any like sub-analysis on those specific types of bacterial infections? Like we know that the procalcitonin is really responsive to urinary tract infections versus bacterial pneumonia, it does not perform as well. So have you guys started to look at those?
We have not started looking at each specific bacteria, but that is part of what our next step is going to be now that we've increased the patient population by about threefold. All right, thank you.
I'm Merritt Ten Health, for those of you that don't know me, and my project was comparing the social needs of readmitted and non-readmitted pediatric patients at our freestanding children's hospital. The WHO defines social determinants of health as the conditions that people are born into, the conditions that they live, grow, work, and thrive. That contribute to their health, well-being, and quality of life. And the Healthy People 2030 initiative breaks down social determinants of health into these 5 domains. So education, access and quality, healthcare access and quality, economic stability, neighborhood and built environments, and social and community context. Children with unmet social needs are at increased risk of lower caregiver reported wellness, more frequent hospitalizations, developmental delays, abnormal anthropometric measurements, worse outcomes in chronic diseases, and higher community and in-hospital mortality. And so the AAP in 2016 released a policy report on poverty and child health that as part of larger efforts to decrease the disparities that contribute to poor health, recommended screening for social determinants of health, and that recommendation was reaffirmed in 2021. One of those significant health outcomes that can be affected by social needs are readmissions. So there are several studies that look at ICD-10 code markers of readmissions or geographic markers of social needs, including the Childhood Opportunity Index and the Area Deprivation Index, showing that patients with more social needs have higher rates of readmissions. This is also true in several specific disease processes. So higher rates of readmissions in patients with asthma and diabetes when they have greater social needs. And we know that hospitalizations can be financially and emotionally costly for patients, and then obviously financially costly for hospitals as well. So that indicates a need for us to do things to help reduce readmission rates. The literature about screening and providing resources and how that can help reduce readmission rates is pretty scarce, especially in the pediatric population. There are a few studies that look at the outcomes of screening and intervention processes, mostly in adult patients, showing that they do reduce utilization and 30-day readmissions. And then there are a couple of pediatric studies where social needs screening and intervention bundles are grouped into greater discharge efforts, discharge bundles, and those bundles do reduce readmission rates, but it's hard to sparse out how the social needs screening actually affects those readmission rates. And there aren't any studies currently prior to our study that compared social needs between readmitted and non-readmitted pediatric patients. And so the idea was that if we're able to identify needs that are more common in our readmitted patients, then we could use that knowledge to target our screening and intervention processes to potentially reduce readmission rates in the future. So the objective of my study was to compare, based on items used in a standardized social determinants of health screening tool, the proportion of patients with specific social needs and the average number of needs per patient between readmitted and non-readmitted patients at our hospital. This was a retrospective observational study. We included patients less than 18 years of age that were readmitted within 30 days to the hospital medicine service from the beginning of October 2022 to the end of January 2023. And then because we knew that we would have a much greater number of patients who are not readmitted, we included a randomized selection of patients without readmission to the hospitalist service who were admitted within that same study timeframe. We excluded adult patients, so anyone 18 years of age or older. We excluded scheduled or planned readmissions, excluded anyone admitted to the biobehavioral or the inpatient rehabilitation units, and then if they didn't have a completed social determinants of health screening tool within our study timeframe, we excluded them as well. There is no standardized screening tool that is recommended for use in inpatient pediatrics. So here at Phoenix Children's, starting in October of 2022, we released a standardized screening tool that was created by a group of physicians, administrators, and stakeholders that was created for an enterprise-wide screening process so that anyone who comes into contact with a Phoenix Children's facility, outpatient, inpatient, ED, gets screened. We adapted this tool from existing screening tools, existing screening processes in our outpatient clinics, the ACEs and the food insecurity screening, and we came up with a list of questions that we felt would be relevant to kind of all of our patient population. This is the tool as it was at the beginning of this study. It's since gone through a couple of adaptations, but this tool is sent to patient families via text or email, and then they're able to answer it electronically. They get real-time resources if they identify any needs, and then everybody gets a link to 211.org. So just a big resource bank that they can look up any sort of resources that they need. And then this completed questionnaire gets uploaded into their EMR. So we were able to see the results. We collected demographic information, including age, race, gender, primary language, zip code, and insurance type. And then we also collected the primary diagnosis category for each patient. And then the answers to each of the questions on the screening questionnaire and their total composite score or the total number of needs that they identified. And then we compared that information between the two groups. And so here is the results of our demographic information. So our patients were 47.9% white, primarily had Medicaid as their main type of insurance. The average age was 5.3 years, majority male, 52.5%, and then majority English speaking, followed by Spanish. And then majority lived in Maricopa County, not surprisingly. There were no differences in any of the demographic characteristics between readmitted and non-readmitted patients. Interestingly, we did find a difference between the most common primary diagnoses of our two groups. The top three were the same, so respiratory, GI, and infectious illnesses were most common in both groups. However, in our non-readmitted patients, the more of them had respiratory illnesses than in our readmitted patients. We didn't delve into why that occurred. My suspicion is that the study took place in the kind of late fall and winter months. So likely a lot of our non-readmitted patients were for respiratory illnesses, things like bronchiolitis, who were otherwise healthy kiddos that didn't end up being readmitted. And then moving on to the results of the screening tool. So there were, again, no statistically significant differences between our two groups in any of the individual social needs. And then nor was there a difference in the average number of needs per patient between the two groups. But I will direct your attention to the very bottom row of data showing that 26.7% of all of the patients had at least one or more social need, which in my opinion is not an insignificant number. More than 1/4 of our patients having had social needs. The top 5 most common needs that we identified were food insecurity, needs for childcare, transportation, housing, and mental health resources. We have access to the data from the enterprise-wide screening from March 2023 through August 2023. And looking at that data of the inpatient screening that was done, which included other services besides just hospital medicine. But those results showed also around 24% of patients having one or more social needs. The top 5 were the same, just in varying orders. And then in our emergency room screen during that time frame, there were 19% of patients identified with one or more social needs, and again having the same top 5, just in a little bit of a different order. So although we didn't find any significant differences in social needs between our readmitted and non-readmitted patients, again, nearly 27% of our patients had one or more needs, with the most common being food, childcare, transportation, housing, and mental health. Again, we talked about those results being pretty comparable to the enterprise-wide screening. And to me, that indicates that we should be screening at every admission and readmission, maybe even every encounter. Hospitalization specifically provides a kind of a different type of care than in outpatient. Patients see multiple different types of providers at probably more frequent intervals than they're seeing in the outpatient setting. So there's lots of opportunities to screen, lots of opportunities to ask about different needs and provide resources. And especially for patients who this may be the only encounter with a healthcare provider that they're going to see for a while, or that they've seen in a while. So they might not have access to outpatient services that they would be screened otherwise. Some limitations to the study: we had a relatively small sample size, although we did power the study to detect a difference if there existed one. There's an electronic tool that we used, so potentially we are disproportionately not including patients who don't have access to the electronic tools that were needed to complete the screen. The initial goal of the project was to screen patients only every 180 days. So when we were creating this study, we weren't going to be able to look at like how a patient's needs changed from the time of initial admission to readmission, because they wouldn't have been screened at their readmission. That didn't end up being the case, and patients were actually screened more frequently than every 180 days on accident, but we didn't know that at the beginning of the study. And because of that, again, the screening tools that we used could have been completed during any time frame from beginning of October to end of January, and not necessarily associated with the specific admission or readmission used in the study. We know that needs can change over time. So because of that, we might not have been accurately capturing the needs of the patient at that specific admission or readmission. We didn't include patients 18 years of age or older who we know are becoming a greater population at pediatric hospitals and are more likely to have complex chronic diseases. And we know that in itself is a risk factor for having unmet social needs. So we could have been excluding a proportion of patients who actually did have greater social needs and greater readmissions. And then we also only included patients admitted to the hospitalist service. And again, we talked about patients with unmet social needs and complex chronic diseases are at higher risk of readmissions. So the patients admitted to specialty services may have a different set of social needs that we were capturing. So kind of along those lines, some future directions that I think are important to address, both in regards to our screening and then in future studies. I think it's important that we continue to address the frequency of our screening intervals and whether or not that's more frequent than every 6 months or even at every encounter or every admission. We have to obviously weigh that against the potential harms of screening fatigue, both for families and for providers. I think it would be interesting to include patients admitted to other subspecialties and adult patients for reasons that I just discussed. Future studies can look at the differences only using screens from the specific encounter, so only the screen from that admission or readmission, looking at how needs change. If we are able to screen more frequently, then potentially we could look at how a patient's needs change from their index admission to a readmission. We can look at differences in needs for specific diagnoses. There's a lot of literature on asthma and diabetes, but not a lot on other different types of diagnoses. And then I think the most important piece is screening is great, but to really impact change, we need to know how the resources that we're providing are actually affecting families and whether or not they're actually useful and have impact on meaningful health outcomes. So looking at how the resources that we provide actually affect patients and their families. Thank you to Dr. Tucker, Dr. Hall, and Dr. Gage, my research and fellowship mentors, Hamey, who was my statistician, and then my SOC committee. My references, and then I will be presenting a poster about my study at SHM, and then currently working on a manuscript for full submission to publication. Yes.
I was focusing a little bit on that exclusion criteria of patients that did not complete the survey. You mentioned it in your limitations, but not only not having electronic devices, but not being able to read the survey or embarrassment about what their needs may be. There's so many other things that can impact that. How do we begin to capture those patients? Because I think they probably have a lot of things that we're not even.
Yeah, that's a good point. And I didn't mention the screen is only available right now in English and Spanish. So I think it's important to remember that our patients speak other languages than just English and Spanish. So potentially in the future, working on coming up with identifying what are the other most common languages spoken at Phoenix Children's and how can we get the tool to those patients. To your point about kind of the shame and fear about admitting what needs they have, written screening tools have been shown to have higher response rates and like higher actual identification of needs than verbal screening. So I think this actually is probably a better tool than going into the room and asking a family verbally what needs do you have, which is kind of what we were doing before this process. So I think this is a step in the right direction, but there's still always going to be some of that stigma around social needs, and that's I think why it's important to screen frequently, because then the patients are seeing those questions, they understand that this is something that I'm going to get asked and potentially would feel more comfortable with answering after having seen it so many times. So far.
Do you know, I have 2 questions. Do you know what the screening rate was, like what percentage?
Can you repeat the question?
The question was whether we know what percentage of our population completed the screening tool, and I don't actually know the answer to that question.
I do know the enterprise
Mhm.
answer to that question, which is 90%. So it's actually one of the best completed screening tools of anyone that
Yeah.
we have, but I don't know for your particular population. But my other question was, do you know, or did you change the process in addition to the resources you mentioned early on that are given kind of automatically when people did screen positive? Did you have a different process in place?
No, not at this point. The question was whether we have a different process related to this project of providing social needs or resources for the social needs identified outside of what exists for the enterprise-wide screening process, and we did not. We don't have anything currently outside of providing those electronic resources when they complete the screening tool. Yes.
You had mentioned the limitation being electronic screening. Has there been any discussion of including this screening tool in the pediatric profile paperwork that nursing
So that was actually a discussion back in during my residency project with when I was doing this more as a QI of like how can we distribute the screening tool, and there were certain questions kind of alluding to social needs in that nursing profile, but there was a lot of variability of how these things were being asked or if they were even being asked, and so we felt like getting the screen directly to the family with the questions already written out was a more like standardized and accurate way of getting results.
Are we able to see the results of that in SCM?
Yeah, anyone can see the results of the screening tool if it's completed. If you go to Smart Chart and then in the links of documents, testing materials is where it's located. And then usually it's pretty easy to find. It's just one of those links.
One question from the chat that you can repeat, but we're kind of getting at it then. It says, were you able to collect data on if the resource lists provided were being utilized to address a need?
No, so that's kind of one of the future directions, and I think one of the most important pieces to take away from this is looking at how resources are used and whether they actually are helpful and families are able to get what they need from those resources, and then how does that affect readmissions. And I think right now in the outpatient setting, they're working on setting up a platform with case managers who can help families follow up and make sure that they're actually getting access to the resources that they requested. And next up is Sagar.
All right, I'm Sagar, and my portion of the talk is pediatric resident billing and coding, evaluating current practices, barriers, and training needs. And so before I kind of get into the details of the project, I kind of wanted to address the motivation behind this project in general. And so medical education has been something that I've been really passionate about since starting fellowship. And my first week on service, when I started fellowship here, my attending had asked me, what's your experience and familiarity with billing and coding? And I felt at the end of residency, I was really ready to practice clinically, but I knew almost nothing about billing and coding. And so combined that passion for medical education and this issue with not knowing anything about billing and coding really served as the impetus for this project. And it's funny because after 3 years of residency, 2 years of fellowship, a research project dedicated to billing and coding, and I still feel like an amateur when it comes to billing my own notes. And so I think that just speaks to the ambiguity, the complexity of billing and coding itself, and the potential need for creating a strong foundational knowledge early in training so that we can have a little bit more comfort with this topic. And so I think we know a lot about documentation and the importance of documentation. We know that it decreases risk for errors. It provides a smoother handoff between providers. It's required for medical legal purposes. And I think what hits home to me most is the time. Like, we spend so much time documenting. So I think it's important for us to know what should be in our notes and how we can do that efficiently and effectively. And just to highlight that a little bit, there was a survey done out of clinical pediatrics in 2018 that surveyed residents. And in the outpatient setting, 37% of trainees said that they spent more than half of their patient encounter time documenting. And in the inpatient time, that raises to 62% of trainees said that they spent more than half of their patient encounter time documenting. And so if we're spending so much time documenting, again, I think it's so important to be able to know how to do that effectively and efficiently. And then that also ties into billing and coding, and the importance of that really is tied to the cost and financial implications of billing and coding. And there's 2 articles that really highlight that point pretty well that I had found in our literature search. The first, that top article was essentially a study that out of Mayo Clinic in Minnesota that was published in 2010 that looked at an internal medicine clinic in the outpatient setting. And they essentially looked at 100 random notes that were done by that were divided equally amongst interns, second years, and third years. And they wanted to see how effectively those residents code their notes versus 3 independent reviewers. And this was one of the few clinics where the residents were able to bill and code their notes like almost autonomously. They had supervisory assistance from attendings, which essentially meant that they could ask questions if they had anything, but otherwise their billing and coding was kind of final. And so they compared what those residents did to 3 independent reviewers and compared to see if there was any significant discrepancies based on the same documentation. And ultimately they noted that for each, there was significant downcoding, particularly with regards to the interns, which makes sense. And they tried to choose notes that were done in the middle of the year, so interns had enough time, residents had enough clinical exposure to make it make sense. But there was significant downcoding that they noted across all 3 years. And when they extrapolated, they essentially calculated a value, like a dollar amount for each patient encounter in lost revenue based on downcoding. And they extrapolated that over a full academic calendar year and noted that there was a loss in about $450,000 in lost revenue for this clinic based on downcoding. And so while half of that was attributed to interns, the other half was attributed to second years and third years, which we can assume will then translate to newly minted general pediatricians. And so I think this speaks about like volumes to the necessity for teaching early on. And while that was done in internal medicine, there was another article done in pediatrics, which was published in 2001. And within pediatrics, there's also almost no clinic that allows residents to bill autonomously. And this clinic essentially, it was done in DuPont in the East Coast, and they had residents shadow bill, which was like pretend billing, and compared what the residents billed to what independent coders would bill, the same documentation. And again, noted significant discrepancies between what the residents were billing and what the coders were billing the same documentation. And there was significant downcoding in the residents, irrespective of their level of training, which again, just speaks volumes to how important it is to potentially teach on this topic earlier on in training and the financial implications of downcoding. And so downcoding essentially results in less money received for provided services in a very general statement. And then upcoding, if we're not coding appropriately and we're upcoding notes, that opens us up to audits, healthcare fraud, and extreme cases. And so neither of these are ideal scenarios or things that we want to open ourselves up to. And so again, stressing the importance of teaching on this topic early on. And I think so far we've talked a lot about the necessity from a systemic standpoint, from a financial standpoint on why this topic is important, but what do trainees have to say on the topic? And that same survey that I talked about earlier in 2018 of clinical pediatrics also asked residents how much training do they receive on this topic? And 62% of trainees said that they had no training in billing and coding, and over 70% felt that they could have used additional training during residency on this topic. And then another survey that surveyed anybody that had passed the pediatric board exam in 2009 looked at essentially the same question, and 81% of generalists and 78% of subspecialists indicated that they could have used additional training in billing and coding. And so in my eyes, I was like, all right, we have a need, we've identified a problem, we have a need, so let's just develop the curriculum. And so that's kind of what we did initially. And we created a social media-based bite-sized videos that we were going to deliver to the residents. And we piloted it with our hospital medicine faculty. And essentially, we noted that there's a little bit of a mixed feedback. And so we essentially took a step back. And given my history and doing a master's in medical education, I was like, we should really step back and think about Kern's 6-step model and framework on why it's important to kind of go through each step accordingly. And so while we've identified a problem, we've also done a kind of a needs assessment. Well, we haven't done a really formal well needs assessment yet. And so that's kind of where we took a step back. And instead of just doing a targeted needs assessment and addressing what's being done locally here and the need for it locally at PCH, we wanted to see the needs nationally as well as the current practices that are being done nationally, so that when it comes time to creating a curriculum, instead of creating one from scratch ourselves, maybe it's important to see if other people are doing it well, we can maybe utilize that same curriculum in that regards. So the objectives of my study is we've essentially created a survey, and the survey objectives are to characterize current billing, coding, and documentation curriculum and practices at pediatric residency programs nationwide. We want to describe the unfulfilled needs surrounding resident preparation to bill and code independently. We want to determine the perceived importance of educating on this topic and assess barriers to educating on this topic. Our secondary objective is to identify the ideal way we should deliver this content. So come up with the content and the delivery method of this topic as well. So the methods for this survey, the population that we're trying to address is pediatric residency program directors. And we want one representative from each program nationwide to fill out our survey. And that was mainly because we didn't want to skew our results in the favor of larger institutions. So smaller institutions might only have one person, whereas larger institutions might have multiple people that could address it. And so we picked residency program directors because then we can have one person from each institution respond to the survey. We created the survey using Typeform Survey Builder, and we had a mix between qualitative, quantitative questions. So there was Likert, multiple choice, and only a few free text questions. And then instead of just creating the survey and disseminating it nationally, we wanted to make sure that we could refine the survey and make it the best version of itself before doing so. And so we tested it at 5 different institutions, mainly in the Western APPD and a few other programs nationwide, via brief semi-structured interviews. So essentially I met with some of the leaders within the Western Association of Pediatric Program Directors, and they kind of went through the survey with me and gave me feedback on how it could be improved. And that kind of played a significant role in making the survey a little bit more tested. And just to give you a little bit of a taste of what the survey looks like, I didn't include all the questions, but just to give you an idea of what it looks like, I have some screenshots of what that looks like. So the initial few questions were demographic questions. So we wanted to get an idea of the age range, where they're from, how long they've been in their current role, and how far out they are from training. Then we also wanted to get a little bit more information on, do the residents at your institution receive any formal education on billing and coding? And then we had some logic built into the survey to see how long has this survey, if they answered yes, then how long has this curriculum existed? Who teaches it? And then what does it focus on? Is it inpatient focused? Is it outpatient focused? And then what does that curriculum look like? How is it delivered? And then lastly, we wanted to see if you were able to create a curriculum in an ideal context on this topic that's otherwise very dry, like how would you want it to be delivered? Is it a single lecture, a workshop, webinars? We use social media. Is that something else that might interest you all as well? So just to kind of get that context as well. And then the last 2 questions were the only 2 free text questions that we incorporated. And they really address what barriers would you expect to face if in implementing this curriculum, or are there any potential drawbacks or concerns associated with implementing this curriculum? So in terms of next steps, our survey we just submitted to the Association of Pediatric Program Directors. And if it gets approved, essentially the APPD will endorse the survey and NAG program directors, Dr. McGreevy and others, to fill out that survey on our behalf. And then we would anticipate data collection to conclude by July of this summer, after which we'll do data analysis. Hammy, our biostatistician, has been really helpful in providing information on like chi-square t-testing and ANOVA testing for the Likert and multiple choice style questions. And then we've talked a lot about like the qualitative analysis for the free text questions. And I think for those 2 questions that we have, we're planning to review them grossly for themes. And then there's cloud-based research software like Deduce that are available to like input some of that information and process some of that information for us as well, which we've left open for interpretation based on how the data looks like. And so that's kind of where we're at so far in the project. And I wanted to give a big thank you to all these people who have been super helpful. Paul Tran, Vasu, Nehal has been super helpful. Sandy, Jamie, who's no longer with us, has been still really helpful in this project. John McGreevy has provided a lot of feedback. Doxa and Hami have also been all very, very helpful. So I appreciate all of their support. And these are my references. And then open any questions, suggestions, tip, advice, anything. Feel free to tell me now or in the future. Yeah.
Is this a part of our, is it a requirement of our curriculum
For ACGME, so at the end of residency, ACGME states that you should be ready for autonomous practice. But there is no guidelines or support that says you have to have a curriculum on billing and coding. Yeah.
In your research, did you see if there are pediatric specific curriculums available currently?
Yeah, so there's nothing that's been published yet. And so there is one needs assessment that has been done, but there's no study that has looked at what curricula exists, and there's no published literature on any pediatric specific billing and coding curriculum. Yeah.
How do you reconcile what maybe my interest is and how I would like it to be delivered versus everyone else that's in the room and how they might like that?
Yeah, totally. And I think that's what like my thought was, let's do it via social media. Let's make it fun. Let's make it interesting. And then I got mixed feedback. And so I was like, instead of me making that interpretation, I think it was important to see what people are doing nationally, what people would want to do nationally, and kind of go from there.
Is this program process going to continue once you leave?
Yeah, I mean, I hope so. I don't think there's any barriers to that. So yeah. Well, All right, thank you.
Barriers, but is anybody gonna take the?
Uh,
mean, it seems
I
like-
will continue it irrespective of PCH,
it
but
seems like
yeah.
something that's very much needed, but
Yeah.
but it hasn't materialized yet.
Yeah, fair.
I think we got a couple of minutes left. Maybe we could have one more question for each if you all want to go up. Give a chance for those out in Zoom land to, if they want to submit anything else, we're doing it.
I guess generally, I'm just start for future fellows. There's a lot of future fellows in here. What advice would you have for current or future fellows about how to make a project successful or lessons you learned along the way?
Well, the question was how, or if we have any advice for future fellows about how to make a project successful. I kind of talked about this, but my residency project was a QI study about implementing social determinants of health screening. And so I thought that I was going to just kind of adapt that and bring it into my fellowship project. But with the new enterprise-wide screening, my project, that initiative kind of was already like being encompassed by that process. So I had to kind of take a step back and revamp and rethink. So how can I still do research in an area that I'm really interested in, but not what I thought I was going to be doing. And just, I think, one, having great research mentors, and having, we're very lucky to have that just the hospitalist group that we do, and all the advisors and clinicians at PCH who are really helpful in helping me kind of rethink ideas. So I think the biggest piece of advice is it's okay if their project doesn't specifically go the exact direction that you want it to go, but know who to ask for help, and how to just be flexible and know that there are lots of people there to help you out if you feel a little bit lost.
Yeah, the only thing I would add is, as the only fellow that is still working on their research project and doesn't have results, I would say that fellowship is short, and so it's important to take something on that's bite-sized and manageable, and it doesn't have to be something that's novel and that was world-renowned changing. And so do something that's passionate for you and something that's manageable, I think is important.
Yeah, and definitely ask for help, talk to people. Mentors will really help guide you through the whole process. And if you're really looking for ideas on like where to start research, a great place to look is like anytime the AAP sends out new guidelines, they always at the bottom have a list of like future research ideas, gaps in the knowledge. So it's a really great place to start looking to getting ideas.
We got a question in the chat for Sagar. So can you repeat this? Okay. Have you planned to include level of care utilization education into your education plan? LOC, level of care, observation versus inpatient versus others, an important part of how the billing and inpatient notes are assessed.
Yeah, so the question was regarding LOC and inpatient versus ob status, incorporating that into the curriculum. And I think that's when we were first creating the curriculum, I thought that was a really important part of it to incorporate, because like when I was in residency, we did our case management rounds, and that was the question I would always be asked. And I was like, I don't know. And so I think it's important for residents to know at least that portion of it. But again, I think we're going to wait and see what the results come out of this, our needs assessment and our assessment of the current practices and barriers, and kind of go from there before we develop a curriculum.
Okay. And I have another question is, how much do you think of the lack of resident education is due to the fact that we attendings ourselves didn't get very good? And we are also created the coders who change the rules every 5 or 10 years. So that, you know, we can remember how we were used to code things 10 years ago, but that doesn't apply anymore.
Yeah, totally fair. So I think Dr. Hartley had said how much of it is due to the fact that we attendings didn't necessarily receive a lot of training, and there's an ambiguity and changing associated with billing and coding constantly. And I think that's accurate. I think the issues surrounding this topic is it's dry, it's constantly changing. And I think that's, again, just speaks to the importance on somebody's got to start teaching this earlier rather than later. But yeah.
I just wanted to thank you guys study really made our schools committee proud of your work, and I love how diverse your projects were. And, you know, from anything to our